2, 1. Sir, we are live now.
Okay, so good morning everyone, and today we have the second talk of our CP module, cerebral palsy module. Today we'll be
Gaurav,
talking
can you show your video? No? You're on.
Sir, I think host has disabled video. You have to enable it.
आप enable कर दो. You can enable, can't you? Okay.
I start when I'll enable it when you're talking.
Yeah, please. That's fine.
Okay. So today the topic is role of single event multi-level surgery in cerebral palsy, and we have Maulin Shah discussing about this topic. After that, we have three interesting cases by current fellows in OrthoKids, Dr. Goda and Dr. James. And yeah, so I think without wasting any time, we can start Sir's talk.
Thank you, Gaurav. And so in our subsequent modules, we are going to talk about different focused talk about correction of crouch and foot deformities and hip displacements. So before that, we thought that let's talk about the concept and philosophy of single event multi-level surgery in cerebral palsy. And all the subsequent modules will be part of this. So how this philosophy has changed over years and what is the current evidence and practice in CP patients. So that we will talk today. Now, if you see the natural history of spastic muscles in cerebral palsy, due to the perinatal insult, the motor area gets affected. And motor area, once it gets affected, there is an ample of presynaptic acetylcholine secretions, which leads to excessive stimulation or contraction of muscles under stress. And in certain age, these muscles are in a phase that they are tight, but they are still stretchable, which we clinically check with modified Ashworth or a Tardieu scale. And this state of muscle where it is tight, but it is stretchable, we term it as a dynamic contracture. Typically, the phase of dynamic contracture in extremity muscles lasts till the child turns about 7 to 8 years old. And after that, the muscles, they are tight and they remain short as well. And this phase of spasticity is termed as static contracture. If these contractures are not dealt with in time, it would induce the joint deformity. And furthermore, the joint deformity, if not treated, it will lead to joint dislocations and arthritis. So this is the natural history of spasticity in cerebral palsy, and we have to react at particular time to alleviate the gait deviations. Till the phase of dynamic contracture, we know that the physiotherapies, neurodevelopmental therapy, botulinum and phenol injections, they help relieving this. But once the static contracture sets in, these drugs would not work, and you have to consider surgical intervention. Now, these surgical interventions, as the children grow, we see that they have a lot of issues. They have deformities, muscle contractures leading to deformities. And they are not at one level. They will be seen at multiple levels. And as they grow, and if their strength is not very good, they would end up into fixed deformities. And they need assistance in walking. And some of these patients have torsional issues also. Their bones are quite significantly rotated. And these torsional issues leads to inefficient gait, and these are also termed as a lever arm disease. So our management of this growth abnormalities, gait anomalies, had multiple components of treatment. For joint contractures, we have to do the muscle recession or lengthening without weakening them. For muscle imbalance, tendon transfers are done. For bony deformities like a knee flexion deformity, we do osseous corrections like extension osteotomies. And for joint instability, we have to do the joint stabilization. For instance, for hip dislocations, we have to consider hip relocation surgeries. Now, all these components earlier were treated with multiple times surgeries, thinking that this patients should not be exposed to bigger surgeries, and they might not tolerate it, and so on, or what previously termed as a birthday syndrome. Every year child would undergo one surgery, but later on it was found that if we deal with all the components of gait deviation, as I mentioned before, the results or outcome of those surgeries were better. Instead of performing annual surgeries, and that was termed as a single event multi-level surgery. So which is defined as combination of two or more soft tissue or bony surgical procedures at two or more anatomic levels. And the goal was straightforward. The goal is to correct all the elements producing gait deviation in one session. If you see current literature, we see that Melbourne group and the American groups have worked very hard in producing evidence about its effectivity. But the first group which coined this concept was from Sweden. Dr. Norlin and group published their first paper in 1985, and they termed it as a one-session surgery. And what they found that once these children undergo surgery at one session, the number of further surgeries is significantly reduced. The families and the children, they tolerate these interventions well. And so they continue to do this practice. However, their interventions were mostly soft tissue realignment and release and transfers. But later on, bony procedures were added by different centers and its effectivity was checked. So concept of single event multi-level surgery probably originated in Sweden. And their goal was to avoid birthday syndrome and consider single surgery. Now the question is, why single event multi-level surgery? We would think that our patients would tolerate small surgeries better. But as in diplegia, we know the muscles are, they cross two joints, and a spastic muscle or a weak muscle would have an adjacent effect. And those muscles who are spanning the joints, multiple joints, they would also have a distant effect or distal effect. For instance, a child who is in crouch, the heel cord is overstretched at ankle, but it leads to secondary deformity of crouch in the knee joint. And they also have a core deformity at the hip joint. The body tries to compensate by flexing the hip, producing anterior pelvic tilt so that the ground reaction force moves in one direction. So if you just address the adjacent muscle, in longer run, they would also have distal effects set in. And so the outcome of your surgery would be suboptimal if you address only one joint. And that's why we have to treat all the elements in one go so that we can provide a good lever arm and the rehab can be robust. Another reason is there are evidence now that the amount of time the child spends in plaster during their childhood, it is directly proportionate to reduction in muscle strength. And the muscle strength reduction is quite substantial in cerebral palsy children. and we have to avoid it. And so the concept of early mobilization has come up after doing osteotomies, and we try to fix with plates and try to make the patients upright as quickly as possible so that their muscle strength is not hampered. It is also well evident now, especially in GMFCS 3s and 4s, that if a child spends a lot of time in plastering mobilization, their bone health deteriorates quite significantly. Now, this child has undergone multiple soft tissue surgery at other center, but child was not walking because there was significantly negative Z-score, and this child required bisphosphonates. The moment it was supplemented, the child started walking. So there are stress fractures, and that we have to take care of. So we can avoid these problems when we perform all the surgeries in one go. There are other advantages like the single anesthesia, single robust rehab program, cost effectiveness for family because they have less off days, and there are evidence now that there are better outcomes compared to single level surgeries. The question would come that what would be the right time for single event multi-level surgery? Because we see a lot of patients, they would end up into a multi-level involvement at pretty early age. So in the original paper by Maulin and group, they have found that by the age of 8 to 10 years, they strengthen the muscles and the brain maturity develops by the age of 8 years. And they divided the children undergoing single event multi-level surgery in two groups, less than 10 years and more than 10 years. And what they found that more than 10 years children, they fare better. Their outcomes were better. And the patients who were less than 10 years, there's still a pubertal growth spurt to come, and they would need further surgeries. The reason why this more than 10 years patients were better, this was questioned that if a child requires earlier surgery, then they are more severely involved. And so these groups cannot be compared. But by and large, in different studies, it is a norm that when children are less than 10 years, you try to control their spasticity and build their strength by using botulinum injection very judiciously, maybe at an interval of 2 or 3 years, and in a right dosage, because we have now found that using botulinum every year may lead to muscle weakness. The spastic muscles may become weaker and they undergo fibrosis. So the current practice is we try to bring the children in adolescence, and anyway, after 10 years, they are good to go. And another concept which is coming up is to prevent crouch by any means, So once the crouch sets in, the lever arm becomes disturbed, and whatever interventions we do, they do not do well. So we want to prevent crouch, a crouch-free society. That's what a concept developed by Melbourne group of people. So we try to inject hamstrings and relax the gastrocs and try to manage them with orthosis to prevent crouch to set in. So right time is ideally after 10 years. Dr. Reinhard Brunner from Europe, they have also found that results are not durable. So single event multi-level surgery is not magic. If you perform in earlier phase, you would need some other supplementary secondary surgeries, and that we have to explain to the family. There are some borderline cases where we have to operate earlier on, and there are new ways how to maintain them or to prevent secondary surgery. Dr. Goda would present one of those cases. What are the preparations for single event multi-level surgery? This we must understand, doing surgeries at multiple level is not the whole crux. We have to prepare the patient and your own team for this surgery. The first and foremost is a pediatrician and anesthetic reference, because they are undergoing a longer operation. So they might need their help later on. We tend to give vitamin D and calcium in therapeutic dosage before a month of surgery, so their bone health is optimized. Some patients who are cognitively not great, then we ask our therapist to do a few sessions and to teach them that what sort of physiotherapy they would have to do immediately after surgery. Some of these patients undergo physio with plaster on. So we have to teach them beforehand. And during the surgery, they need indwelling catheters because at times, you know, there is overflow of the bladder and they might disturb and contaminate your field. So it's a usual practice to put catheters. And for better pain control, epidural catheters should be introduced, and this so your anesthetist team should be equipped enough for this. Post-operatively, diazepam fentanyl infusions, they do very well. There was an recommendation that this infusion should be used in ICU, but we have been using in ward setup, and we titrate the dosage of this, and we know that what is the optimum dose for that particular child. Early mobilization is very important to maintain their bone health and muscle strength. So in-plaster movements are encouraged for these patients. So these are now we are switching from big plasters to braces. And when we have released the hip flexors or actors, we also recommend in prone lying, sitting, mobilization in wheelchair with extended resting support. These all are now done to help our single event multi-level surgery patients. So what surgeries we do, we lengthen the shortened muscles. We shorten the long muscles like patellar plication and all. You will see in subsequent in our cases. Correction of lever arm by correcting the planovalgoid feet, or rotational malalignment like correction of femurs and tibias. And finally, joint deformity correction for subluxation. These are all our elements which we do in as a one session. There are evidence now that those who are working with a value is added by a co-surgeon. So if you have a team, like both the teams can work together, and if you work that way, then the total surgical time, blood loss, and overall cost of intervention reduces significantly. So there are many centers where they have two teams, or if you have fellows to assist you, so that helps in reducing the time of operations. The question comes, which are the best candidates, you know, who would respond well to single event multi-level surgery? And these are the papers which has studied extensively what are the predictors. And they have mentioned that GMFCS 3 children between the age of 10 and 12 years, they do well. Why? Because their FMS or functional mobility scale is very low. So they have high opportunity to improve. And as we mentioned earlier, the GMFCS, the 1 and 2s, they already are performing at better level, and their younger patients would experience some recurrence of deformities because with the growth spurt and with increasing weight. The question though is, we all are talking about single event multi-level surgeries, but what is the evidence that whether the results are maintained longitudinally? If we operate children between 10 and 12 years, do they come back? Because we know that earlier growth charts of CP children, we saw that they have maximum improvement in first 5 years of life. Between 5 and 10, 12 years, they become a bit plateau, and after 12 years, they deteriorate. And that's what we were explaining. So does single event multi-level surgery change the natural history of this deteriorating function after adolescence? And this paper from Kirk Graham and group, they have found that although GMFCS cannot be changed, the functional mobility scale of patients should it improves substantially at 5-year follow-up in single event multi-level surgery, meaning that the patients who have their mobility at home their mobility at school and their mobility at community. So it's very important we try to give this leaflet out to families before surgery. So they quantify their score before we start the surgery from FMS. And after a year or 6 months, we ask them to feel that score again. And that will show them quantitative improvement. And that will keep their enthusiasm alive about undergoing rehab. So I will just share one case that how single event multi-level surgery would help an individual and the results are lasting. And then after discussion, we would have further cases. Now this spastic diplegic child who is working at GMFCS 3, he presented to me with inability to walk independently for longer distance. He had frequent fall while walking. He had a premature birth, but they didn't have any associated seizure disorder or sensory issues. He started independent walking after 3 years, underwent regular therapy. No orthopedic intervention was done so far, and they were from a bit a remote place. No Botox interventions were done. And you can see his gait is fairly unstable and energy inefficient gait. And he would need 1 or 2 adults to make him move in home as well as in the community. Of course, he could not go to the school because of these issues earlier on. And you can see that he has problems at multiple levels, including hip, pelvis, knee, and the foot. You can also see some torsional issues in this boy. And so this boy was referred to us. On his clinical examination, his hip abduction was only 30 degrees. There was no hip FFT or rectus tightness. He had increased hip rotation, internal rotations compared to external rotations. And we confirmed through femoral trochanteric palpation test that it was 25 degrees internal rotation, anteversion of femur. Popliteal angles were 70 degrees, but there was no FFD. And way back, that this popliteal shift test was not devised probably at that time in 2009-10. So I did not find that in my note. His ankle dorsiflexion with knee flexion was -7. So a bit of static contracture he had. He had tip post spasticity and his tibial torsion was okay, which we checked with a prone line 5-foot axis. This is the CT scan we got at that point, and it shows some 30 degrees of anteversion. Now, interventions we did were combined soft tissue and bony procedures. We did bilateral hip adductor release, bilateral medial hamstring fractional lengthening. At that time, this SEMLS to adductor magnus transfer was not devised, so we were not aware about. And this boy had more of jump knee gait rather than a crouch. We did bilateral high TA release and aponeurotic lengthening and tip post fractional lengthening. And we performed bilateral femoral subtrochanteric derotation, external rotation osteotomy in one go. And this is his outcome after 4 years of single event multi-level surgery. And you can see that his gait improved substantially. His stability and endurance also improved. Once we looked him at a longer follow-up, we found that he had some tibial torsional alignment issue also on one side, and I think I performed a tibial derotation osteotomy subsequently. And this boy is now 24 years old, doing a government clerical job. He is independent earning member of his family, and I got an invitation to attend his marriage recently. He's so he is living an independent life, and you can see that this intervention, which was performed before 10 years or 12 years, still he is maintaining his function. One advice I give to this patient is to keep their weight at minimum I have seen the children who are obese, they are not doing well in longer run. So I think that's the message I wanted to share with all of you. The concept behind single event multi-level surgery. I'll be happy to answer if there is any question. Thank you very much.
So thank you, sir, for this very illustrative talk and telling us the importance of single event multi-level surgeries. So now, since we don't have any questions in our chat group, so we'll straight away start with the cases. The first case will be presented by Dr. Gupta.
Yes, sir. Good morning, everyone. We had a 13-year-old boy who presented with complaints of abnormal walking pattern. He was born preterm and there was history of NICU stay. He was on ventilator support for 5 days. Parents reported that he had history of delayed milestones. All the milestones were delayed and he started walking only with support, that too with great difficulty, since the age of 4 years. On clinical examination, his intellect was good. He was walking with crouch gait with support. His selective motor control was grade 1, it was moderate. And his hip examination, there was no FFD, but hip abduction with knees flexed was full and hip abduction with knees extended was 30-30. On examination of the knee, there was fixed flexion deformity of 20 degrees on the left side and 10 degrees on the right. Bilateral popliteal angles were around 60. There was bilateral patella alta. Extensor lag of 45 degrees bilaterally and hamstring power was 3/5. His ankle dorsiflexion with knees extended was +5 on the right and -5 on left, and with knees flexed it was +10, that is was quite positive, and he had bilateral plano-valgoid feet with midfoot break. This was his gait video.
Comfortable hai paji.
This is his gait video, preoperative video. So here we can see that he's walking with great difficulty with the help of a walker, and he has these frequent falls also. Significant crouch is also can be seen.
So, yeah. Go ahead.
So with this clinical features, he was falling into the category of GMFCS level 3, and his functional mobility scale at this point preoperatively was he could only walk for 5 meters, that too with the help of another person or with a walker or a frame. And for a 50-meter distance, like he used to go to his school and all that with a walker or with the help of other person, or he would only use a wheelchair when he had to go about to parks or long distances. So his functional mobility scale was very less. It was only 5 out of the 18 given score.
So I was talking about this, Guda, go back. Go on to the FMS slide.
Yes.
So, we have seen this very well in Erb's palsy patients, that if we have this HSCMS score, which is a quantitative measure of their improvement, if similar leaflet can be given to family before the surgery and ask them to score that how much your child is mobilizing in home, what assistive device he needs at home, in school and in community. So they can plot, and then after 6 months, we can ask family to plot themselves that how much of improvement they have, and that is a quantitative measure. As we know that we cannot change GMFCS, we can certainly make change in the FMS. So this, everyone should try and use this. Now, going back to examination, Goda, go back a few slides about, go back.
Yes.
Yeah, just next slide. So, it seems that he did not have much of the issue at the hip joint, but we were worried that now he has knee flexion deformities, but they were not at great extent. At the same time, hamstring power was also not optimum. So we were at a stage that whether we should consider osteotomy for 10 degrees deformity, or we should do something, because releasing hamstring might lead to further weakening and anterior pelvic tilt. So Gaurav or anyone else, Dr. Anil was here. How would you deal with this child with significant extensor leg? Goda, can you show the video again?
Yes.
Okay. Comfort.
So anyone, if you want to take that, what should be the intervention? Yeah.
Yes, sir. So in this case, since the hamstrings are quite weak and extensor lag is also a lot, which suggests that quadriceps are also very weak.
Yeah.
And
Can you
as the
be a little louder, Gaurav, please?
Yeah. So in this case, as the child has not gained skeletal maturity, I would consider doing patellar tendon plication and anterior hemi epiphysiodesis to correct the flexion deformity at the distal femur.
So the question is, in a presence of knee FFD, if you just do the patellar tendon plication, because your growth modulation or PATs will take some time to work to correct the deformity. For about 20-degree knee flexion deformity, it might take a year to correct. So your plicated patellar tendon will get overstretched. So that's the concern. So
Maulin, Harish here.
yeah, Harish, please.
For these small degree deformities, I usually put couple of casts. They usually stretch out. After couple cast, wets them out. 2 or max 3 casts. These small degrees.
Yeah. So the Harish, this child had undergone casting at other place earlier.
After casting, once the deformity is corrected, because you already said hamstrings are weak, further extensive release may cause more weakness. So what I do for these cases, stretch out with the cast. On table, usually get some amount of correction. When the patient under anesthesia, the knees stretch out, and you can do a patellar tendon plication. So if at all, if there is anything which is required, you can do a limited medial hamstring release.
Right. So this child has undergone probably this casting already, and this is a residual deformity.
Okay.
So the dosage of hamstring, what should be the dosage? That's the question. Now, the dosage ranges from, you do a very high hamstring fractional lengthening. So you do aponeurotic lengthening of hamstrings at a very higher level, and we do not touch the lateral hamstrings because it is important for hip extension. So that is one dose. The second one, which earlier we used to do a semi-T-Z lengthening and fractional lengthening of other gastroc, but that might lead to a bit of weakness. And the third dosage is to transfer the semi-T to adductor magnus and do not touch other hamstrings like semimembranosus gracilis and bicep femoris. You don't touch them, but just you shift the semi-T to adductor magnus. So these are the dosage, and that's what we plan to do in this case. And to see once we do semi-T release, what happens to the knee FFD. But there should not be any knee FFD at the time. If it is there, we should perform plication later on once it gets corrected. So let's go ahead, Goda, and show what we did.
So what we did in this case was bilateral semitendinosus to adductor magnus transfer, bilateral aponeurotic gastrocnemius recession, that is high TA, bilateral Moscas procedure to correct his planovalgoid feet, and left distal femur anterior PETS was done for the amount of fixed flexion deformity of knee which we were not able to correct. Since he had some residual growth remaining, we thought PETs would give him a better correction. So this is a paper which was published in JBJS in the year 2015. This was done by Children's Orthopaedic Hospital, Los Angeles, California. Anterior percutaneous hemiepiphysiodesis of distal aspect of femur. This was the technique which was described. So in this, these are the images from the paper itself. So the one on the right side shows fluoroscopic images, which show the appropriate positioning of guide wires for percutaneous placement of transphysial screws. And the wires should cross distal femoral physis in the anterior third. And the one on the left shows the clinical photographs showing the typical pin entrance sites and the stab incisions which were given later for the placement of the screws. So we went ahead and did the same procedure to correct the residual FFD which was present on the left side. These are the post-operative radiographs. And these videos are of the patient showing 2 years follow-up. His gait has significantly improved now. He's able to ambulate well at home as well as in school. There is no history of frequent falls now. The crouch has also improved. The FFD at the knee has improved compared to the previous pre-operative videos. His functional mobility scale has also improved. The scores have improved.
Can you
So,
just repeat the first half of it? No, I missed it.
pardon, sir?
The first half of the treatment, what was done?
Yes.
Only the epiphysiodesis was done. No?
No, sir.
Sorry?
We have.
Yeah, okay. This part I missed it.
So we have done a bilateral semitendinosus to adductor magnus transfer, high TA release, Moscas for the planovalgoid feet, and then for the residual FFD in the knee, we have done a PETS procedure.
What was the, like under anesthesia, what was the knee deformity? In this
It was 20 degrees on the left side, so.
No, I mean after anesthesia, was it the same or?
Yeah, Hari, yeah, that they were the same, 20 and 10.
Same, okay, fine.
So on this right side, you know, once we did the semi-T transfer, the knee FFD got relieved. But on the right side, on the left side, it did not relieve. It was, so we avoided patellar plication at this point. We just did the anterior pad screw.
Okay.
And explained to the family that we will use an static AFO with a broader proximal strap, which would help pushing the tibia behind in stance. And this child might need an correction, osteotomy and patellar plication later on. So this is 2 years follow-up. We are following this child up. But, you know, he has improved substantially. That FFD has gone. And as Gaurav asked, the knee extension leg is very minimal now. We are working on its strength and see how it goes. We are already will be planning patellar plication if he has the residual knee extensor leg.
The brace, what are you using? AFO, right?
He's using AFO, yeah.
So, but
A static AFO.
Yeah, but there is no knee flexion. So maybe
No.
you may not require patellar tendon plication. In stance, the knee is in complete extension, right?
Yeah. I think he has couple of years growth remaining, and Goda, you can run the post-op video again.
Yes, sir.
But one can see that these children have issues of, you know, what do you say? It's a pelvis and limb dissociation issue. So their selective motor control is moderate. Their strength is moderate. So we cannot expect their GMFCS to jump or improve. They will be what the message is, they would need some assistive device in community walking in school, but their endurance would increase. So functional mobility scale will improve. So we cannot expect miracles, after single event multi, we cannot expect GMFCS to jump. So that's the message.
So, concluding slide. So, PETs can be used in patients with cerebral palsy to correct FFD when they have some growth remaining. And even though the GMFCS does not improve, the functional mobility improves, and the child can do very well when he has to go to school or go on to walk for the longer distances. Thank you.
So the technical tip for this is the pad screw. This younger children would need a 4 mm cannulated screw or 4.5 mm. And then there are, this screw should be fully threaded, and the tip should be kept a little outside for ease of removal if we need. But it's very, we have seen patients with anterior 8 plates, but those anterior 8 plates, they leads to a lot of knee synovitis. And they are very prominent. The screws are, the pain is not there, and they do well with pad screw. So we have switched from anterior 8 plates to the pad screw anterior for knee FFPs. Okay.
So how early you put this? I mean, what is the youngest stage you put these screws? Because it is sort of irreversible, right?
The prerequisite is there should be residual growth, 2 or 3 years growth remaining, then only it would work.
Yes, yes.
And I have done it in fairly young children, not in this cerebral palsy, but I have done one in 7-year-old with a bit of pterygium syndrome and contracted hamstrings, congenital contracture of knee I have used. And then once we remove it, it can come back. So it works well.
So it works like a temporary facial disease because you're putting a screw.
Yeah. So once you remove, we have also seen it as the deformity coming back.
Okay. So it doesn't really work like a permanent facial disease.
No. It comes back because it's occupying very small area. I've done it in pterygium syndromes, and because we need multiple surgeries,
Correct.
Then you can also use in arthrogrypotics with knee flexion deformity. And of course in CP, the group of CP would be the one where there's minimal amount of knee flexion deformity and weak hamstrings. There you can do this.
Yeah. It basically avoids that frequent prominence anteriorly, what we see in anterior 8 plates.
Yeah.
That's a big advantage.
The Sujit, before we move to the other case, the question from Dr. Sujit, what is your indication for hip adductor release? Fleff test done alone or anything else? So, of course, we do that test and make sure that it's isolated adductor release or it's an adductor or gracilis release. But if a child has an tendency of seizuring or imbalance due to inability to abduct the extremity, then we tend to release these adductors. When do you consider removal of pad screw? The removal should be once we correct the deformity completely, and there should be full knee extension. To keep the weight minimum, so what if patient is obese at 10 years of age? So like that, of course, if obese child doesn't mount that, that's not surgical indication, but we have to educate the families, right from beginning, that if you have increasing body weight and you have BMI is high, that you will have to carry your own weight. And we have to make sure that the diet, so we have dietitian also. So we encourage high protein diet, and they should not gain weight. Many times it's a family issue, they do not understand what calories they are consuming. So it's we have to educate them. Yeah, let's move on to the second case.
Good morning, everybody. I'm presenting an
interesting case of a 12-year-old girl. She presented with abnormal gait pattern, and the main parental concerns were limited walking endurance, knee pain, and imbalance. There was delayed cried at birth, and there was no NICU admission following that. And she had a history of delayed motor milestones. She started walking independently only at 4 years. She came to us at 12 years. Till this time, she was on regular physiotherapy, and they did not seek any orthopedic intervention. And this is how she came to us. So we can see that she walks with a crouch gait, and she mainly and her ambulation is limited to her home. Usually, she does not go outside in the community, and when she goes out, she requires a walker even in a school. Coming to static examination, there was no pelvic tilt. At the hips, there was a combined abduction angle of 100 degrees. There was no RF tightness, no hip FFD. Knees, bilateral, the popliteal angle R1 was 60 and R2 was 40, and there was no change with popliteal shift. Bilateral patella alta was seen, and quadriceps lag of 30 degrees was there bilaterally. The hamstrings and quadriceps strength was 4/5, and cervicothoracic test was positive. There was a 20-degree improvement with knee flexion, and both the bilateral feet were plano-valgoid with a midfoot break. Hip extensor strength was 4/5. Selective motor control was good, and there was no rotational malalignment. So she fell in this GMFCS 3 category, and the functional motor score at home, she was at 5, and in community for 5 meters we see at home. For 50 meters we see how the child performs in school, and for 500 meters we see how can they walk well in the community. So pre-operatively she could not go walk in the community, so her score was just 5 and 3 pre-operatively. So the problems we had was crouch, and so the main question was what would be our dosage of surgery for that, and for the plano-valgoid feet, would we correct it now or would we accommodate it?
So Joy, you can go back to your examination slide. Yeah. So anyone can comment or opine about what they would do. If we narrate, the hip and pelvis looks okay here. There's a typical crouch with short hamstrings with good strength. Patella alta with significant quad leg. Along with that, we have gastrocnemius, spasticity, tightness and shortening, and plano-valgoid feet. And there is not much of rotational malalignment as Joy mentioned. So Gaurav, what would you do for this girl?
So as we can see that there is.
Let's play the video again, Joyans. Yeah, Gaurav, go ahead.
Yeah, so we can see that there is a significant knee flexion, and the ankles look overstretched, although the examination says that the crouch was the silver shoulder is positive. There is plano-valgoid feet. So these are the three main problems there. So definitely we need correction for the knee. So I will do semi-D transfer, and I will do this gracilis release from the posterior part of distal femur, distal knee, distal part of the thigh, and anteriorly I will do patellar tendon plication. So this will give me correction at the knee, and then I would be hesitant to touch the gastrosoleus aponeurosis because ankle look overstretched to me, and for both the feet they need correction. So I would do correction of the plano-valgoid by doing the muscles. and I will stage it one lower limb at one time. We'll try to do both in one admission, maybe in 3 to 4 days apart.
Right. So fine. Any other comment? So Gaurav wants to go ahead with semi T to adductor magnus transfer and gracilis release for patella plication and Mosca's procedure without doing gastro recession. Any other comment or opinion? Harish?
I usually do a quick test of asking the child to stand or walk on knees. That eliminates the hamstrings and gives us the psoas spasticity and the check on the pelvic tilt and hip extensor function. Usually, because most of these kids have some amount of psoas spasticity as well. I always combine psoas fractional lengthening at the brim in most of these kids. As you can see, there's still some amount of pelvic tilt. The quick test, what I do is to make them stand on the knees.
So that gives the clue about their core strength as well.
Exactly.
Exactly. Yeah. And
that will give also idea about the truncal control and all.
Right.
We have a reasonable truncal control. But that gives me a fair idea whether I also need to add a psoas fractional length.
Right. So if you have this access to 3D gait analysis, then it will show that double bump sign in the sagittal plane kinematics, which shows that hip flexors are tight. But there are recent evidences that excess release of psoas leads to a weak, a weak early swing phase. So I'm very critical, and if I see substantial knee flexion deformity, then only I'll intervene. And of course, we have to do over the brim psoas release.
Yes.
Right. The second thing, Gaurav, I want to tell you that sometimes, when they are in planovalgoid, you see that the TA is overstretched. But the moment you correct the biomechanics, like do calcaneal lengthening, and you invert the foot, you will see that this TA is short. And then you are not able to, because of planovalgoid, the TA is shifted laterally. And so you know that we have to invert the foot and check what is the amount of tightness. When we mention that overstretched TAs, that means that they are in planovalgoid and there is dorsiflexion at the ankle. But if we invert and lock the ankle, you will see that we are not able to dorsiflex. So, so that this child had TA tightness. So let's see what we have done and what we have got. Yeah, Johannes, we can go ahead.
So this was our plan. We did, and how we executed it. We did bilateral semitendinosus to adductor magnus transfer and bilateral high TA release, bilateral Mosca's procedures, and bilateral patellar tendon plication. And this is her post-op gait video. We can see the crouch is gone and she has a plantigrade foot. And her FMS score improved to 6 at home, 5 at school, and 5 in community. So it came up to 16 by the maximum score, which is 18. And this is a 4-year follow-up. So we can, so her FMS has increased from 8 preoperatively to 16 by 18, and she has maintained it over a 4-year follow-up period.
Yeah, so I think key here was, as Gaurav said, the hamstrings strength is very important. And we earlier thought that only lateral hamstring strength is important, but if you do overzealous medial hamstring release, then anterior pelvic tilt sets in. And with anterior pelvic tilt, if, as Harish said, if there is associated hip flexion deformity, the child is compelled to use assistive device because they will always tilt further. So Gaurav, for anterior pelvic tilt, we check the strength of hamstrings before the surgery. Selective motor control is also important. Most of the kids, they can do against gravity elevation, and then you have to see whether they can do against resistance. If they can do against resistant knee flexion in prone position, then you can do semi-T transfer and fractional lengthening of gracilis and semimembranosus. And if you find that they are not able to do that, so they have only against gravity movement but not against resistance, then you don't touch semimembranosus and gracilis, you just do the transfer. That's how we do it. And if there is any flexion deformity in excess of 10 to 15 degrees at hip, then you do over the brim psoas, and make sure the rectus is also not very tight. So the key thing is, against resistant hamstring strength is there, then you do semi-T transfer along with fractional lengthening. If it is not there, you do just semi-T transfer, not touch the other three hamstrings. So in this case, the same thing we did. Although her power was good, we did the transfer and we did not touch other hamstrings. And probably that she has a minimal anterior pelvic tilt, but you can see that she can get away without using any assistive device in community. Yeah, so Joannes, we can conclude and move ahead with the last case. So yeah, Goda will present last. Any question by the time we come up?
So we had a 13-year-old girl who presented with complaints of difficult ambulation. She was born at term via C-section. There was history of delayed cry, and there was NICU stay for about 21 days. She has history of convulsions and is on anti-epileptics. There was gross delay in delayed milestones, and she started sitting independently only at 3 years of age. And on examination, she had moderate intellect. She walks with support, that to very few steps and with great difficulty. She has crouched gait. In spite of being GMFCS 4, she had a good selective motor control. Her hip examination, there was FFD of 10 degrees. There was no rectus femoral spasticity. Hip abduction with knee flexion was bilaterally 45 degrees, and hip abduction with knee extension was 30-30. The hip extensor power was MRC grade 2. On examination of knee, there was 30-degree fixed flexion deformity bilaterally. Bilateral patella alta was present, and the hamstring power was 4/5. The tendoachilles was stretchable, and she had bilateral planovalgoid feet. This was her preoperative gait. So we can see that she's walking with great difficulty with support. She has crouch gait. She was not ambulatory at home also. She had to be carried to the washroom as well. If she had to ambulate independently at home, she used to crawl or walk on her knees. And this is her gait from the lateral aspect, lateral profile. Significant crouching is present. And very difficult to mobilize without support. She can just take few steps. So with this, she was a GMFCS 4 because she had to use support and had great self-mobility with limitations. And her FMS score preoperative was only 3 out of 18 because she had to use support or wheelchair, support at home, and had to use wheelchair when she had to walk in the community. So what we did in this...
Go back.
Yes.
I mean, the point of discussing cases is to discussing it what we think. Fine. So let us have a comment on Gaurav or other what we would do. And going back to examination, Huda, can we see the examination slide? Yeah. So here now, this girl is has crossed her puberty, and with the pubertal growth spurt, parents witness that her mobility has deteriorated significantly. She has gained weight, and to shift her from bed to toilet or to dining area, they need a lot of support. And she is worsening. Her knee FFDs is progressing. So you can see there is minimal FFD at hip. There is limited hip abduction with knee extension. She has pelvic and extremity dissociation was also not very good. But though she could do things independently, like she had good selective motor control. Next slide, Goda. And then bilateral knee FFD of 30 and patella alta. So how would you react to this, Gaurav?
Yeah, sir. So apart from the severe crouch she has, I can see that there's a lot of outgoing and the patella are squinting medially. So I want to know about the
Rotational profile.
also. Yeah.
Surprisingly, I mean, we didn't find much of the rotational malalignment in this child. The planovalgoid is mainly producing this external rotation. Goda, did we have any mention about rotational malalignment?
No, sir. No, sir.
The other thing is what we can expect in terms of outcome of this child. That is very important. What we should tell family, that whether doing multiple surgeries would help her or not.
Yeah.
What should be the goal?
So we should counsel the family that definitely correcting the knee flexion will help the child in having a more energy efficient gait. But yes, we can't ensure that she will become independent walker ever. Although we can try our best with therapies post surgery.
So that's very important, that a GMFCS4 would not jump to a GMFCS3 unless her physiotherapy has not been optimized. Now, this girl was receiving therapy for many years, and the family is quite supportive. So she was at her optimum level, So she was a really GMFCS4. So that is the first thing we have to explain, that we can improve the FMS, meaning her mobility inside the home, but we cannot change her ambulatory level. And we have to drive the family's expectations to a real level so that there is no conflicts or dissatisfaction after the intervention. But a minor improvement would also help this family, because carrying this adult, almost an adult child, to the activities of daily living, it's a huge problem, especially when parents are growing into their 50s. So we have to help them, but with this this goals clear. And what would you do for this significant amount of deformities, Gaurav? Would you go for soft tissue release, or you do something?
Since she has fixed flexion deformity, I don't think doing soft tissue will correct it. So rather touching the soft tissues, I'll go for bony correction, correcting the flexion deformity, and if there is any rotational issue, we'll correct that too simultaneously.
Right. So, and knee FFD in an adolescent and knee FFD in younger child are different. In younger children, we would do a limited hamstring release, and we do casting, sometimes the pad screws, because with the increasing length of bone, the lengthened hamstring will become relatively shortened again, and they will gain the strength. But FFD in adolescent, we want to preserve whatever hamstring power they have, because we know that the anterior pelvic tilt will become very disabling. And it is also very challenging for therapists to overcome that hamstring power, hip extensor power. So we have to preserve their muscle power. So I agree with you that we must go ahead with an osteotomies rather than doing soft tissue release. One more. What is your way of doing patellar plication? I will ask to Harish and Gaurav. Have you been practicing the same as you saw with us, or you have changed a bit?
Sir, I'm doing the same.
Doing the same. Yeah, Harish?
I don't know what
Is he
we
here?
have been doing.
Harish,
Yeah,
how do you do patella plication?
I make 3 slips. I don't detach any of them.
Yeah. So
Listen.
you kind of double press it and suture it. That's what you do?
Yes, that's what I do.
Okay.
Oh,
Anyone else? They do some augmenting like fiber cable or SS wire with the plication or distalization of tuberosity. Anyone else? Fine. Let's see what happened with this child and what we did. Goda, please move ahead.
So we did a bilateral distal femoral anterior closing wedge osteotomy and bilateral patellar tendon plication. We did a double breasting of tendon by winding it over an artery forceps and then suturing it.
So that is
2.5.
Heinz technique of plication. And Goda can share that paper with all of you, mentioning different ways of doing plication. Yeah.
2.5 months post-surgery, while the child was on physiotherapy and she was in prone position and the physiotherapist was trying to improve her flexion movement, range of movement. And suddenly she had to sneeze, and this led to a sudden snap was heard after this and followed by excruciating pain in the left knee. And she was not able to do SLRT nor range of movement after that, and she was referred to the center. And on examination, there was a palpable gap in the mid-substance of the patella, in the operative the site of the left side, a significant gap in the mid-substance. And she was not able to do straight leg raising. And we sent her for an MRI, and the MRI revealed patella tendon ruptured in the mid-substance. So this was we went and looked for literature, and we could not find any case report where patella tendon was ruptured after the plication in a case of cerebral palsy. And,
so here we have not shortened the tendon. I mean, cut and shorten. We have just double breasted, and with the Heinz technique, we have double breasted it and sutured. But this is probably the first case report where the patella tendon has shown mid-substance tear during rehabilitative therapy. And Goda will show you the literature and what is the recommendation. So it's very important for therapists to understand the rehab protocol, and there are prescribed strategy of rehabilitation after a crouch and after patella plication. So we'll share those papers as well. Yeah, Goda, show what we did.
Yes, sir. So we intraoperatively, once we gave a midline incision and opened the site, we saw that the tendon there was mid-substance tear along with fraying of the margins of the tendon, and it could not be repaired by itself, direct suturing. So we had to augment it, and for augmenting it, we have taken fascia lata strips. 10 into 3 centimeters strips were taken. A strip was taken by a separate incision on the lateral aspect of the thigh. And then this long strip was divided into 3 separate pieces, 3 parts, and 3 strips were placed to augment this repair. And this is 1 year post augmentation and repair of it. She is now able to do SLRT. She has good range of knee movements. We do not see any palpable gap in the tendon. And we have done an ultrasound examination instead of an MRI because the child was claustrophobic. And this USG examination shows good continuity of the tendon, which was augmented. So it has been augmented well. The strength of it is also maintained. And this is a 1 year follow-up mobilizing videos, gait videos. Now she's able to ambulate well. Initially, she was not able to independently walk even at home. She needed some support, physical assistance, and now she's able to walk with the help of walker and take few steps without the help of walker also. She's able to go to school independently with the help of a walker. But for community walking, now she still requires a wheelchair assistance for longer distances. So for her FMS scores have significantly improved. And these are her recent gait videos. So from 3, it has improved to 6. What is important from this case is the rehabilitation of children with CP after single event surgeries. So this is a chapter which has been published by Kerr Graham and Thompson. This has stages of rehabilitation. So about 10 stages are present. The preoperative planning, inpatient stay, the first 3 weeks, 4 to 6 weeks, 7 to 12, 13 to 24, 6 to 12 months, and 1 year post surgery. So this is how the children have to be mobilized or rehabilitation has to proceed. So in the first post-operative period, the post-operative positioning is very important. So we have to teach the patient the prone mobilization as soon as possible in the post-operative period, because it maintains the length of iliopsoas. And progressive elevation of the bed is also required for long sitting, and it is also effective in stretching of the lengthened hamstrings. And the 4 to 6 weeks, if the child has not undergone any bony procedure, they can be immobilized in the first 3 weeks itself. And if the child has undergone some bony procedure, there will be a little delay that we can start weight bearing after 3 weeks. So within the first 1 to 3 weeks, all the children who have undergone soft tissue procedures can ambulate. Weeks 4 to 6 are very important period, and the priorities in this week to 4 to 6 are regaining of the muscle strength and encouraging the weight bearing and reintroducing of walking, because the dynamics of gait have been changed after surgery. So we have to reintroduce walking in this phase. And we should, as soon as possible, graduate the child to crutches, to forearm crutches in the early 4 to 6 weeks. After that, the 7 to 12 weeks, they have to start doing strengthening and functional exercises. And they have to walk with the help of an AFO only, except when they are doing hydrotherapy. That is when AFOs can be removed. And rehabilitation progression from 13 to 24 weeks. Here it is to reduce the dependence on wheelchairs and the posterior walkers. So children should move with the use of forearm crutches. They should be able to walk independently, if possible, that is, and children should also commence to difficult tasks like supervised use of stairs. This should also be started in the weeks 13 to 24. And rehabilitation progression from 6 to 12 months. Here resistance training can be started, and gym-based activities can also be started with standard equipments. So the conclusion from this is post-operative protocols after single event multi-level surgeries are very crucial, and they have after we do a patellar tendon plication or a knee flexion deformity surgeries, they have to be progressed gradually to improve the knee range of movements. Any aberrant or acute sudden or forceful improvement in knee range of movements might lead to this patellar tendon ruptures, which we have seen in this case. So this gradual progression to improve range of movement is very important.
So the therapists tend to do core strengthening in high kneeling position. Now all these patients need core strength, so they put them in high kneeling position. But once you do patella plication, that high kneeling position should be avoided. This paper shows that more than 90-degree of flexion should be attempted after 1 year of patellar surgery. In India, we have need that or family that my child needs to sit cross-legged. So we have to explain to the physios as well as the family that the cross leg setting should be avoided for at least 1 year after this surgery. And the core strengthening with a high kneeling position should be avoided, because if child does not have good control, they may need to this complication. And we are on the verge of publishing this in JBJS case report. So we have done 2 revisions, and I'm sure that this will get through and will get published into JBJS. Fine. So that was nicely presented, Goda. So I think, Gaurav, we will conclude if we don't have any question, and we'll share. I'll ask Goda to share this paper. We have very important paper in our fellows group, so that all can learn from that.
Both the papers, one the techniques for patellar tendon plication and the rehab paper, both are very important. And I would also like to tell that we have 4 or 5 more lectures coming up on CP. So the next upcoming lecture is on 15th, that's the Saturday, but on use of Botox in cerebral palsy by Dr. Chasna.
Right. So thank you everyone for your participation from India and abroad, and I wish you all the best. Have a good weekend. Take care.
Thank you, Maulin. Bye.
Yeah, I'll stop the meeting now. Okay. Nicely presented, James and Goda. Thank you.
Thank you.
Thanks, Gaurav.
Thank you so much.